Yeah, so good morning, everyone. Hope my screen is visible to him. I'm Dr. Munjal Pandya, mentor and coach, hemato-oncologist and transplant fellow. And I'm going a bit much in faster way to solve maximum MCQ. Later on, we can discuss. This is all our team. We have all hard copy book, data flow services, mock tests, past paper, recalls, discounted packages, and all. This is one important thing I would like to again re-emphasize. We have excellent YouTube channel, right? Those who are not in the class or coaching, I strongly recommend you have fortunately the privilege to access this YouTube channel at no cost, right? Premium material. So you better subscribe it and try to see at least one video a day, right? So that would be excellent. And we have mobile application on the Android and iPhone as well. So whatever the phone you are using, Android or iPhone, you must download this. This is on the Android and this is on the Apple. So this is the same logo you can see, right? While you are searching for this app on mobile application, right? So whole the website you can access through the mobile phone as it is, right? So this is quite recently updated with the better look and feel and speed as well, obviously. So you subscribe it and you download it, so that would be helpful for you as well. So without wasting the time, I'll just jump onto the questions very quickly, and then we'll do the this later on the feedback things. So first questions in front of your screen. This is a question. A 40 years female presents to you with abnormal cervical cytology on pap smear suggestive of CIN3. The next best step in the management is hysterectomy, colposcopy and LEEP, colposcopy and cryotherapy, conization. These all are the recently high yield this things I recently compiled, recently asked in exam by the few students, send me the recall. So I'll just try to compile that. Here I need to know what is the cervical cancer screening guideline. I want to know the vaccination for cervical cancer, which strain they covers. What is OSCAS and how you gonna treat it, and read guideline cervical cancer screening in pregnant lady and immunocompromised. So these are almost 10 to 15 question in one slide. So I want you to understand all these things in one go very quickly with the good conceptualized things. So you can post your answer in the chat box. A 40 years quite young woman presents to you with abnormal cervical cytology on pap smear suggestive of CIN. CIN stands for cervical intraepithelial neoplasm 3. What is the best next step in the management? You have A, B, C, D, E. You can post your answer in the chat box. I'm muting all because I'm getting a lot of background noise. So you just post your answer, or you can unmute your mic and you can do it. I want to know the treatment of CIN 1 and 2 as well, not just the 3, because they may ask you anything in your exam. So what is the treatment, Dr. Lalit, of CIN 1? If you have patient of CIN 1, how you treat? If you have CIN 2, how you treat? If you have CIN 3, how you treat? Yes, you can now open up your mic.
Yes, sir. For CIN, we don't usually treat it. We just repeat the pap smear after 1 year. In CIN
One
2 and 3, we
one
do
year
the. Yes, sir, after 1 year.
after 1 year. Okay, fine, fair enough. But okay, what else? And CIN 2 and 3, how you gonna, approach these patients?
Leap, sir. Colposcopy in leap.
For 2 and 3, both you gonna go for this leap?
For 3, I'm sure. For 2, I can't remember.
Yeah. So if you have a questions of CIN 2, right? The same questions, instead of 3, let me do it. Here the 2, not the 3. Then what would be your answer?
Still, I will go for leap.
Here 2 or 3. Yes, all expert can comment. Anything can come in exam. I'm just taking the one example of 3. But they may ask you what is the treatment of CIN 2, then how you supposed to answer this question? Yes, anyone, any gynecologist or any gynec expert? Yes. Yes, anyone wants to comment? How you gonna treat CIN2?
The
Okay,
leap same.
fine, fair enough. So if the cervical dysplasia is more severe, CIN2 and 3, right, it is recommended to remove or destroying the abnormal cells. And this procedure can cure cervical dysplasia in about 90% of the patients. And that includes first is the LEAP. What do you mean by LEAP? So LEAP is a loop electrosurgical excisional procedure. So you must know the things as well. What do you mean by the LEAP? So L means loop. This first E is electrosurgical. Electrosurgical.
Excision.
Another E is excision, just for our clarity, and P means procedure. Is that clear to everyone? Right? So CIN1, usually they don't need treatment. You can observe and you can repeat the pap smear. CIN2 and 3, they are a bit more, this have a tendency to go into the invasive carcinoma. So we'll see it, right? So first thing is a loop, right? This is one options, right? Another option also you can opt for, right? Cone biopsy, but standard is first, and third is hysterectomy as well. If the patient's family is finished, right? But this is bit more aggressive options for the patients to go for the hysterectomy just for the CIN, which is not even invasive carcinoma, but it is there in the guidelines. So it patient's choice, right? So you can do it, right? So most of them, you had given the correct answer B. Now, can anyone tell me, right, what is a cervical cancer screening guideline, right? So for the sake of the answer of this question, right, colposcopy and leap is the answer for this questions. Let's go to the screening guidelines. So can anyone tell me what is a cervical cancer screening guideline? Four things I want to know. What is the start age? At what age you start the cervical cancer screening? At what age you stop cervical cancer screening? What frequency you gonna do the cervical cancer screening? And what is the name of the test you gonna do for cervical cancer screening? And these four things applicable to all screening. If you don't know, you need to know five screening. Just write down in your notes. They can ask you. This is absolutely high yield question. These four things you know for all this: cervical cancer, breast cancer, colon cancer, prostate cancer, lung cancer. Ovarian cancer, as such, there is no screening guideline, right? CA125 is not absolutely used as a screening test because it does not reduces the mortality. But for this five, here the example is cervix. So you need to know the four things for this. If you know for the five cancer, means you are getting 20 MCQ, right? By in one slide, there are 20 MCQ in this slide, right? So can anyone tell me all four these things, right? Cervix, what is a cervical cancer screening guideline in a general population? Anyone?
The age is 21.
Pap smear.
One by
Start
one,
at
one by one,
21
one
years.
by one. First, start with the start age. What is the start age? At what age you
21
supposed
years.
to? 21.
21 is started.
Fair enough. At what age you stop?
65.
65.
65.
65.
65
What frequency you gonna do?
3 years.
every
Every
3
year.
years.
Every
Every
3 years.
every 3 year. And what is the name of the test you gonna do it for
Pap smear.
survival?
Pap smear.
HPV.
Pap
Wonderful.
smear.
Pap smear. Pap smear. Wonderful. Now I will twist this question, right? If I can say, right, if you want to do the dual test, means you want to do a pap smear, and if you want, and I want to do the HPV DNA virus as well. What is the start age? What is the stop age? What is the frequency? What is the name of the test?
The
I'm
pap
not doing
smear
it.
frequency is 5 years.
Okay, great,
So
wonderful.
the
So this
HPV,
is the major,
Thirty
HPV
wonderful.
years.
frequency is 5 years.
Right. So this is the major change. The frequency is
Yes,
5. This is not changed. This is almost the same, right? And here instead
yes,
of PEP, here PEP plus HPV.
Yes.
right? So this is the answer. So you need to know, if I can ask, right, if the patient as a HIV positive, is there any change in the this schedule 1, 2, 3, 4, anything change in start age, stop age, frequency, or name of the test? Does it change if some 23 years of female comes to you, she is HIV positive and asking you, sir, how I supposed to do the cervical cancer screening in my case I'm having HIV positive and I'm on antiretroviral therapy. Is there any change, or by and large would be the same?
It is depending upon the immune system, CD4 of
Sorry,
the person.
depending on what?
CD4, the immune system.
Okay, so
After
let
starting
let me
ART,
let me tell you, CD4 count is now 500.
the same as normal person, because the CD4, if it is above 500, then the person has good
Okay,
immune
if I
system.
can say you CD4 count is 200, then
Every year, these
every year. So usually in immunocompromised patient, especially the HIV patient, they are high risk of developing the cervical cancer. So you're supposed to do it annually. This is a special. So this is what the thing is. Read the guideline of cervical cancer in pregnant lady and immunocompromised. So if I ask you, the pregnant lady comes to you at the 25 years of age and asking the cervical cancer screening, what is the change in this form? Is there any change? Scenario is like 25 years of female, healthy female, primigravida, right? No complaint at present, presents to you now with the 5 months of gestational age and asking you about the cervical cancer screening. What's your advice? Are
3
you
years
getting my
before.
question? Yes or no? Are you getting my question? Yes or no?
Yes.
Sir.
Yes. So are you comfortable
Yes.
doing the cervical, this
Hmm.
swab and all in a pregnant patient? You are not worried
No.
about bleeding or miscarriage or something like that
Yes, therefore we have to postpone in postpartum age.
in postpartum age? Okay. You can't do it in third trimester?
Yes, you can.
Okay. So somebody is saying postpone to post-pregnancy state, right? Somebody is saying, yes, you can postpone to third trimester of the pregnancy. Any other things? Fine. So that is your homework. I'll not tell the answer. Otherwise, gonna not read this. So each and everybody go and read. This is the recently asked questions in exam, right? So we are not trying to solve the easier questions only, lollipop questions, right? Pregnancy plus cervical cancer screening. Cervical cancer screening. What's the protocol? Is that clear to everyone? Yes or no?
Yes.
Yes, sir.
Wonderful. This is homework. This is homework. I will remember. This video is with me. Fine. So we saw this is your homework, right? This is your homework. Sorry to give you the homework, but it's important. So guideline we have seen. Now come to the next. Lots of question with this. First of all, cervical cancer screening. Sorry, cervical cancer vaccine, or shortly better word is HPV vaccine. So now tell me, age, what age is recommended to give the cervical cancer vaccine globally? If some female comes to you and ask you, right, what is the ideal age or what is the recommended age between which I supposed to take this cervical cancer vaccine? Number one
18,
question.
12 to
18 years
14.
old. 18.
What is the lowest age?
12 years.
Sorry,
12
18 years.
years.
you can
Before the first intercourse.
post it in the chat box. Someone is saying 11 to 26, one is 12.
Nine,
Atulya is saying
9
12.
to 14. 9 to 14.
Sorry,
9 to 14 years.
9 to 14. Okay, so one is 9 to 14. If I can ask you, if the 15 years of girl wants to take this vaccine, she cannot take?
You
She
can take
can.
it.
I mean, the started from the 9 to 14, then
Yeah, tell me. So you tell me the age group. No? This is very common question in ask in the exam. Very common question. My question is very clear cut. Give me the age range, right? Which one the lowest age I supposed to give this vaccine, and which one is the highest age as per the guideline. No, it's not your or my belief. right? As per the book, all international book, what they recommend, lowest age and highest age. Now
9
you
to
answer.
45. Yeah,
9
9
to
to 40,
Wonderful. So lowest
45.
is 9 and highest is 45. So this is the correct
45,
answer.
yes.
This is the correct
Yes.
answer. Wonderful. Second thing is this is the age, number one. Number two, schedule. Schedule means how many doses you supposed to give. So is there any change if you give at the 9 years of age and if you give at the 45 years of age? Is there any change in the dose or schedule? Second question.
Yes,
Yes, sir. 9 to 14, 2 doses.
9 to 14, two doses, right? What is
Yes.
the distance between two doses?
6 months.
6
6
6
to
to
months.
12
12 months, sir.
months.
So,
6 months.
Yeah, 6 to 12
so
months.
ideal is a 0 to 6 as per the book I'm going. If you are taking
Okay.
at 12, well and good within 12 years, but standard is 0 to 6. So two doses, right? Just for clarity. Right? Now 45 years of female, if you want to give, is there any change in the schedule or it is also 0 to 6?
3 doses.
Three doses. What is the schedule? First dose at
0,
what? First dose
0,
is,
0, 6,
first dose is 0. Second dose?
6, 6.
I think so, 1 month, and
Zero within
second
2
month
months, sir. Second dose is within 2
within
months.
2 months.
Wonderful.
Within 2
So
months.
ideal guy, every guideline says 2 months, but some guidelines say 1 month as well. So I can put it as a broad term, 1 to 2 months. Ideal is 2 months. And is there any third dose or just two dose?
So 3
Third.
Three dose.
doses. 3
Third dose. So
doses.
third dose at what interval?
6 months.
6 months. Wonderful. So this is final. So let me do the little fine adjustment. The lowest stage is 9 and highest stage is 45.
45.
And in 9 to 14, let me tell you little more precise. 9 to 14, right? You supposed to give the two dose with 6 months apart, and 15 to 45, 15 to 45, because 9 to
3
14, then what
doses.
beyond 40, then this is the doses. Is that clear, everyone?
Yes.
Yes or no? At least tell me yes or no. You are with me or
Yes, sir.
not?
Yes, sir.
Yes, sir.
Wonderful.
Yes, sir.
This is one very much we need to completely crystal clear in this. Second, third thing, right? Third question. Age we cleared, right? 9 to 14, two doses, 6 months apart, 15 to 45, three doses, 0 to 6
3
ideally,
doses.
but you can give it in. Sometime they says if somebody missed the 6 months of dose, first dose 0 taken, second dose at 2 months taken, third dose missed. Some lady missed by any reason, forget about reason, any reason. So guideline is saying within 12 months she can take anytime the third dose. Is that clear? Yes or no? These all are
Yes.
the various questions in your exam. They take you round, 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 but this is bottom line I am telling you. Third question, which strains they covers? Which strains they covers? Right? At 9 months, 9 years of age, if you are giving this, and at 45 years of age, you are giving this, is there any change in the strain or there is no change in the strain? Which strain covers in this vaccine? You had given first dose, you had given second dose. Here you had given first, second, and third dose. So which strain covers this vaccine? This is all about the vaccine. We are talking about the vaccine. We are talking all
HPV
about.
6, 7, 16, and 18. Sir.
Okay. So
Okay,
let me tell you 6, 11, 16, and 18. This is the vaccine schedule. It is given for all, right? So 0, 6, 0, 2, 6, anything. And this four vaccine in a one vial, it is called as a quadrivalent. Is that clear? Yes or no? At least tell me yes or no.
Yes.
If along with this four, you add more 5 strains of HPV, right? It is called as a nanovalent. Both are available in the market. Is that clear? Yes or no? Yes or no?
Yes.
Fourth
Yes, sir.
thing, four options. This cervical cancer vaccine is given subcutaneously, intramuscularly, intravenously, or you can also take oral as well. Answer.
IM.
Intramuscularly, IM.
IM. Okay, IM. Is there any side preferred? Gluteal region or anterolateral
Deltoid muscle.
thigh, deltoid, or any other muscles if you come across?
Deltoid muscle or anterolateral thigh.
Deltoid. Excellent. Wonderful. So this is now end of this cervical cancer vaccine. They will not going to ask you anything more than this. Is that clear to everyone? Yes or no?
Yes, sir.
right? So this is specific thing you must know for each and everything, right? So we don't need to miss it anything, right? So cervical cancer vaccine now you knows, right? Cervical cancer vaccine strain, what you cover you knows, right? This is your homework, so I'll not tell you. What is a Oscars? Can anyone know the full form of Oscars?
A typical squamous cell
Atypical
squamous cell
squamous cell
undetermined
undetermined significance.
Significance.
Okay. So if
survival.
you, yes, so if you do a pap smear of a 25 or 30 years female, right, in a routine screening, you found Oscars. What is your next immediate step or next best step in the management of this patient? You did a pap smear. Pap smear is showing Oscars. What's your
HPV,
next step?
we go with HPV DNA.
Directly you go with the HPV DNA.
Colposcopy.
Okay, let's see HPV. You did it in Oscars. You did HPV. What if the HPV is positive? What would be the next step? What
If
if the HPV is negative? What is the next step?
it is positive, we do colposcopy and biopsy, sir.
Excellent. So this is very much clear cut. If you have HPV positive, because HPV is 90% plus patient who has a cervical cancer, they carries HPV. So HPV can cause this dysplasia, metaplasia, carcinoma in situ, and eventually the invasive carcinoma of cervix. Is that clear? Yes or no? So if you have a positive HPV, then colposcopy and biopsy. If you have a negative HPV and Oscars, what you supposed to do? When you call the patients to do the repeat pap smear after 3 years, 2 years, 1 year, or 4 year, or 5 year? MCQ.
1 year.
3 years.
1 year.
After
Okay.
1 year,
So somebody is saying 1 year, one is saying 3 years. Is there
3
any other
years.
answer?
6
months.
if it was not Oscars, then the
Negative.
it will be 3 years.
Another answer is a 6 months. So what is the correct answer?
1 year.
6 months.
If negative, then 3 years.
Oscars is negative than 3 years. So what I
Yes, sir.
know, Oscars can be present. This is atypical, does not mean always cancer. So it could be likely normal. It could be because of infection, and it could be because of malignancy, right? Any reason, even bad, very infection in the genital tract, right? You may see some kind of abnormal cells, right? Or atypical squamous cell of uncertain significance. You don't know the significance. It could be normal, it could be infection, it could be malignancy. So once you have this, but what we would not like to miss is malignancy. So if you have like little Oscars, still you want to go for 3 years, or you want to do it bit earlier?
1 year.
6 months will be preferable, sir.
Okay, fine. So by my knowledge, right, it is a 1 year the answer, but you cross check it. If you have Oscars, what you supposed to do? By my knowledge, it's 1 year, because you don't know, na? It could be a malignancy, so you can't wait for 3 years. If it is normal pap smear, then you go for every 3 years. Again, after 3 years normal, again go for 3 years. But Oscars is not normal. Oscars is not normal. Definitely, there is a risk of malignancy, though it is a small, but it is there, right? So you cannot afford to miss this. So you want to pick up this in early stage, in situ stage, without invasive carcinoma. So you must do it by my sense earlier. The answer ideally is a 1 year, but you go and look into it. Is that clear to everyone? Yes or no?
Yes.
Fine. So let's conclude this cervical cancer. This is the final picture of the cervical cancer. So let me give you, because it is absolutely high, very high yield questions in all exam. So this is what the thing is. You need to know what is CIN. You don't need to mug up, right? Though we solve 2 questions late, it's fine. But if anything comes to you with this question, 100% you must know, right? So CIN1, it is mild dysplasia. This is all epithelium is absolutely normal. This is normal, healthy looking epithelium. What happens in CI1? Cervical intraepithelial neoplasm. So within epithelium, there is some kind of neoplasia or dysplasia will develop, right? Which is less than 1/3 of the thickness, 1/3, right? So if you complete this, This is 1/3, 2/3, and complete whole thickness. So we divide whole thickness in three parts. So less than 1/3 part is involved is CIN. 1/3 to 2/3 part is involved, right? This is CIN 2, right? CIN 3 is more than 2/3, but not 100%, more than 2/3. And when there is a complete thickness of is involved, it is called as a carcinoma in situ. The biggest difference between carcinoma in situ and invasive carcinoma is basement membrane is intact. Here the basement membrane is gone. So now they are invasive, they are invading surrounding tissue, and this is called invasive carcinoma. So these are the stage: normal, CIN 1, 2, 3, carcinoma in situ, and invasive carcinoma. Another important thing, if someone has cervical carcinoma in situ 1, right? If you don't do anything, they progress to 2, right? They progress to 3, they progress to carcinoma in situ, and they progress to invasive carcinoma or invasive carcinoma of cervix, right? This journey will take around 10 years. So now if somebody is in CIN1 by 2035, she may probably develop this just general understanding, and this is what we observed over a period of time. Unfortunately, we are very less patients saying with CIN 1, 2, 3. Being a medical oncologist, most of the patient present with the cervical mass. So they present with the, this is uterus, this is cervix, and they present with the cervical mass here. And commonest presentation of this patient is, right, post-menopausal bleeding or post-coital bleeding. This is number one presenting symptoms, right, of the cervical cancer, right? This is how the ovary, fallopian tube, and cervix, right? So what you do enter the spatula and take a pap smear from here, and that is why. So say for example, some lady has a CIN1 which is going into the CIN2. So if you do the leap here, the problem is solved. They will not going to go into the invasive carcinoma because you treated them. But if you don't do it, this will absolutely progress from this direction to this direction. And here there is no role of pap smear. Now you have to treat. You have to treat. There is no prevention. No vaccine will helpful. Vaccine is for prevention, not for the treatment. For your kind knowledge. Once you have tuberculosis, it is no need to take BCG vaccine. Once you have poliomyelitis, no need to take a polio drop. Once you have hepatitis B and liver cancer, hepatocellular carcinoma, no need to give hepatitis B vaccine. All vaccines are meant to prevent the disease, not to cure the disease. Is that clear to everyone? Yes or no?
Yes.
Yes, sir.
Wonderful. So this is what the complete clear cut. I think there is no confusion in this picture. I love this picture. So this is absolutely clear cut. So many a times people they mug up CIN1, but they don't know what is CIN1. They don't know what is CIN2. They don't know what is CIN3, and they don't know what is carcinoma in situ, and they don't know what is invasive basement membrane. Here you can see the basement membrane is intact except invasive carcinoma. Here cell breach the basement membrane. Is that clear? Yes or no?
Yes.
Right?
Yes,
So
sir.
don't mug up now. So you need to remember. So this is what the extremely important things. These are the various technique, not going much in detail of this. So this is the answer for this question is this, right? Let's jump to the next question. Though we do less, but if you have 10 questions or you have 2 questions with cervical cancer, now your chapter is done. Still you go and read it. So it is absolutely rock solid now. 53-year-old male with past medical history of IgA deficiency and diverticulosis, present with a lower GI bleed and found to have acute blood loss anemia. Several minutes after starting a blood transfusion, he becomes agitated. On examination, fever, tachycardia, hypoxia, hypotension, wheezing, bilateral lung fields, and tongue swelling. What type of hypersensitivity it is? Type 1, 2, 3, 4. None of the above. Those who answer me, give me one example. What is the type 1? What includes what? What is the mechanism? And how you gonna treat? How you gonna prevent? Type 2, 3, 4, same thing. One example for one hypersensitivity reaction. Your time starts now. In exam, you have hardly 10, 15, 20 seconds. So you need to read, you need to interpret, you need to answer, and you need to go ahead. Take your time for 10-15 seconds. Try to understand what the exact problem is with the patient, with the IgA deficiency. These all are the recall.
Type 1 allergic rhinitis.
Type 1 hypersensitivity
Yes.
reaction. Okay.
Yeah, asthma, allergic rhinitis.
Okay.
Immediate reaction.
Fine.
IG
Post answer in the chat box. I will pick up. ABCD. Post it like ABCD. Yeah. We are more than 30-40 doctors, but comment is 2 only. Yes, Dr. Nagin. Any comment from your side, Dr. Nagin Mahmoodi? Would you like to comment on this? Yes, doctor.
Hi, doctor. I think it's a type 2 hypersensitivity reaction.
Okay, so type 2 and type 1, how you gonna differentiate? What is in type 1? What
Type
is in
1
type 2?
is because of the release of immunoglobulin E and mast cells, but type 2 is the foundation of complex immunoglobulin and antigen.
Okay. So what is the scenario says? What is the diagnosis of the scenario? Anyone knows what is the
Hemolytic
diagnosis?
anemia after transfusion reaction.
Okay, so after transfusion, if some patient has, let me understand from you, that brings clarity to you. So after transfusion, so this patient is transfused, right? Right? Lower GI bleeding and acute blood anemia several minutes after transfusion. So they had given the transfusion for anemia. Why? Because patient has a GI bleeding. That is why they have anemia, they had transfusion. After transfusion, patient if develop the fever, if patient develop the tachycardia, if patient develop the hypoxia, if patient develop the hypotension, if patient develop the wheezing, right? In the bilateral lung field and tongue is swollen. Is there any term for this? Can you give one name for this things where everything happen? Tachycardia, tachypnea, hypotension, hypoxia, wheezing after giving the blood transfusion.
Anaphylaxis.
After forming the anti-IgA antibodies.
Right. So is there, if you don't mind, can I give the name? Probably patient has some kind of anaphylactic
Anaphylaxis.
reaction. Yes or no?
Yes, sir.
Yes, sir.
Anaphylactic reaction or shock, because hypotension is shock basically. Okay. So this anaphylactic reaction, right? It is immediate or delayed, or because of what, or what type? Now your job is easy. This anaphylaxis happens because of
So
what?
anaphylactic is acute.
Acute. So anaphylaxis is usually acute.
Minutes, within minutes.
Right. So within minutes, right? Within minutes. So they are saying several minutes, maybe 5, 10, 15 minutes after transfusion. So it's acute, right? So
Sir, it may form the anti-IgA antibodies and react severely to the donor blood containing IgA.
great, wonderful. So what kind of this acute kind of things is seen in what type of hypersensitivity? 1, 2, 3, 4.
Sir, type 1.
Acute is type 1, sir.
Wonderful. So answer is type 1. Acute is answer is type 1, right? Acid is a acronym. I'll come to you. Acid is type 1, right? A for anaphylaxis. So if you have acid, just acronym for easier for you to remember, it is anaphylaxis. So let me go to the literature now, right? So see, this is first, remember acid, right? Remember hypersensitivity reaction, HRS here written. HSR means hypersensitivity reaction. Think acid. Acid means type 1. Type 1 is acid. So whenever this things comes, it's easier. I'm trying to make your job very, very easy, right? For that, I need to do a lot of research before presenting to you, but it makes your life easy. Allergic, immediate, anaphylaxis, blood transfusion, anaphylaxis, atopic asthma, somebody told me, right? So allergic, anaphylactic, atopic means A is done. So if you find in exam allergy after this, anaphylaxis, or atopic asthma, it's type 1. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
If you want to remember type 2, this is the most easiest. I do a lot of research to get this slide, right? I was thinking how I supposed to remember 1, 2, 3, 4 in easier way. And by doing the research, I got this slide. So I make it for you. So this allergy, anaphylaxis and atopic is type 1. Type 2, right? So acid A is gone. Acid A means what? A means allergic, A means anaphylactic, A means atopic. Is that clear? So A is
Yes.
type 1.
Yes.
So in acid, A is type 1 and A includes 3: allergic, anaphylactic, atopic. What is the C? C means cytotoxic. Cytotoxic. That is type 2. I means immune complex. Immune complex. When there is antigen antibody anywhere in the body, it's type 2. And acid, D for delay hypersensitivity. That is 4. I think this is the most easiest way I can explain you. Is that clear? Yes or no?
Wonderful, sir. Wonderful mnemonic.
Wonderful. Thank you very much for your kind feedback. So we are always confusing ourselves. What is type 1, type 2, type 3, type 4? So you don't need to remember now onwards anything. Only acid. Any anaphylactic acid, right? Acid. If you remember, then you can answer any question. It is simple. You just need to look into the scenario. What is there, right? That's it. So this is acid. Now I think probably whatever the answer you had given, that would be changed now onwards, right? So now let's go to the 1, 2, 3, 4 little bit in 2 minutes detail, right? So type 1, as Dr. rightly told, Dr. Abhishek, I think she is very well mentioned what is type 1. So type 1 is acid A, right? Anaphylaxis, and it is IgE mediated. So you need to know what is type 1, how these things happen, right? So how this, right, atopic and anaphylaxis is type 1. It is what mediated? Which? So IgE mediated. And classical example is urticaria, angioedema. This patient has angioedema. See, this patient has a thick tongue. I don't know whether you observed it or not. This is a angioedema. So swollen tongue is angioedema. Swollen mucosa, right? Mucosa, mucous membrane, tongue and larynx is a angioedema, isn't it? Yes or no? Right? So
Yes, sir.
angioedema is also there, but I think probably missed in our reading the MCQ, but I remember. So each and everything is matching in the scenario. So urticaria immediate, angioedema immediate, anaphylaxis immediate, atopic immediate. So acid is done. Is that clear? Yes or no? Whatever the story they give you in the exam,
Yes, sir.
forget about everything. You need to know the basic thing. That's it. This is how you become more expert, right? See cytotoxic, see the first line, cytotoxic reaction, right? What it's mediated through? It is not IgE, absolutely not IgE, it is IgG, IgM. You need to remember what are the example: blood dyscrasia, hemolytic reaction, right, where there is a RBC, and on RBC there is an antibody. Autoimmune hemolytic anemia or hemolytic anemia, where you IgG, Ig mediated thrombocytopenia or hemolysis. Autoimmune hemolytic anemia, autoimmune hemolytic anemia, AIHA, or immune thrombocytopenic purpura, blah blah, autoimmune. So that happens because of antibody, that is IgGM mediated. Is that clear? Yes or no?
Yes, sir.
I, right, is a immune complex formation. So immune complex formation, when there is a immune complex formation, it can form any part of the body. Antigen and antibody complex will develop, usually IgG or IgM. Again, this is more commonly IgG, but IgM is also responsible. And deposition of this complex, both complex, immune complex, either they deposit in the skin, they deposit it in the kidney, they deposit in the joint, they deposit in the GI. Commonest is serum sickness, vasculitis. So any vasculitis type 3, if they give you the scenario vasculitis, don't get confused, because in vasculitis what happens? There is the antigen and antibody complex formation. And when there is a complex formation, immune complex formation, I means immune complex formation, and D means delay. D means delay. You did it something today, it will develop later on. So delayed cell mediated, and delayed is usually the T cell mediated or T cell mediated. Here nothing to do with the antibody. Here there are 5 types of antibody. Those who forgot the antibodies: IgG, IgA, IgM, IgD, and IgE, right? So only delayed is T mediated. There is nothing to do with this immunoglobulin. Is that clear to everyone? Yes or no? Right. So delayed cell mediated hypersensitivity reaction, T cell mediated, and can be further divided in blah blah. We don't need to do research in this all cell mediated, but you, for the sake of the exam, you must know, right? Contact dermatitis. So you wear some bangle, you wear some mangal sutra, you wear some chain in the neck, right? Immediately nothing will happen. There is some delayed hypersensitivity reaction, Steven Jogren syndrome, blah blah blah. This is all delayed. So something you do today and develop after few days and weeks, it is delayed hypersensitivity, usually T cell mediated. Is that clear to everyone? I try my level best to make it more simplified. Now, what's your opinion again on these questions? Is it correct? Everybody's agreed with type 1 hypersensitivity, or yes or no?
Yes, sir.
Agree, sir.
Sorry, sir.
Agree.
Wonderful.
Agree.
Thank you.
Agree.
Thank you very much for agreeing with me. Wonderful.
You can't deny anymore.
That is your kindness. Somebody is agreeing with
Sir,
me, their
do it
kindness.
have to do anything with the IgA deficiency?
Sorry?
Sir, do this the last question. It mentioned that it has the patient already have IgA deficiency.
Yes, so
Does it affect the answer?
yeah, because IgA deficiency patient, right? If you give this IgA, this blood transfusion, so this is a specific subset of the patient, IgA deficiency, and if you give non-IgA deficiency, transfusion reaction will going to happen, and that is what happened in this patient, right? So that's it. This is why otherwise nowadays there is very rare anaphylaxis I can see because I'm in hematology for quite many years. So we do blood transfusion, platelet, cryo, precipitate, prothrombin, complex, concentrate, blah blah. But we never had much bad transfusion reaction or anaphylaxis like this, what they describe in this scenario. But it can happen with this such type of so IgA deficiency. That is why it is specifically mentioned. So you go and bit read more in detail. So this is
Sir,
what,
in
and
first
this
aid
is
in first aid book, the blood transfusion reaction is written in the type 2 reaction.
sorry.
But the scenario you have mentioned in this question is of typical is the classic answer of the type 1
Yes,
reaction.
yes,
The in first aid book, the blood transfusion reaction is clearly mentioned in type 2 hypersensitivity reaction.
yeah.
How to discriminate between the type 1 and 2 or type 2 in type 2 in the blood transfusion reaction?
Basically, you need to look what is the primary etiology of these things, right? So if you find the etiology, if you have, you need to have, see, type 1, type 2, 3, 4, you can't get it by just some antibody level. You need to see the history, you need to examine the patient, what is the vitals of the patient, at what time frame they develop, immediately versus late, blah, blah. So this all things will keep in the mind, but this is the bottom line. All four type of hypersensitive reaction can be drug induced. So this is high yield point. These 3 points are high yield point. So I marked and highlighted here just for your better clarity and for exam point of view. So all four type, either 1, 2, 3 or 4, hypersensitive reaction can be drug induced. So if you have in exam, you need to think what it could be. Number, this is high yield. Number 2 high yield is type 1 and type 4 hypersensitive most commonly manifest cutaneous. So type 1, when there is a type 1 as we see, right, angioedema, mucosa, mucous membrane, tongue swelling, laryngeal swelling, laryngeal edema, right? So type 1 and type 4, that is delayed acid, D is D4, D is 4, right? If I'm not wrong, D acid, D is 4. So delayed,
Yeah.
and they both most often involve cutaneously. So whenever in your exam something cutaneous comes, you are like you need to differentiate between 1 and 4. 2 and 3 is gone usually. Is that clear? So this is tips and tricks, right? So type 1 and 3 and acid I already told you. So by and large, you should keep generally all the things in mind and then give the answer. I mean, there is no one answer for every question, but you must keep in mind. So let's move to the third. We need to catch up with all questions. You go bit more in detail, but anything can more be discussed on the our WhatsApp platform. You are called
Okay.
to house of 69 years old female whose neighbor came to visit and found her unable to speak without slurring her words, right? You arrive to find an elderly female seated on the couch appearing very frightened. She attempts to talk but it is unable to appropriately form her words. The neighbor is present who does not know the patient's past medical history. BP is 126/78, pulse is uh, 18, sorry, respiratory rate is 18, pulse oximeter, oxygen saturation is 98% room air, and heart rate or pulse rate is 76, looks irregular. What is the most important amongst the below options? DNR, do not resuscitate the status. When was the last time the patient was seen without symptoms? The phone number of a relative, you take a phone number and call to relative. What medication does the patient took?
B answer, sir.
Right. So first of all, try to understand the MCQ. What is the diagnosis? What is the differential diagnosis? What it could be? Why the patient has the symptoms? So first you need to first figure out. So as every time I'm telling you, each and everybody, probably I did not draw. This is the triad. I loved it, and I do it in my daily practice for last 20 years. Any patient comes to me, I'll ask myself, what is the diagnosis of this patient? Once I'll make a diagnosis, chest pain patient comes to me, I'll make, oh, possible acute MI. Then I'll do the ECG, and then I'll treat the patient. So this triad is extremely important for each and every MCQ. Those who are joining me first time, if you are solving 50 MCQ a day nowadays, right, your target, if you ask these three questions, then same 50 will convert into 150. So though you are doing 50 MCQ, but end of the day you are solving the 150. Why? Because now you need to know diagnosis, now you need to know investigation, now you need to know the treatment. So we don't need to mug up. Ask three questions. So in one question, there are three questions. So this question, can anyone tell me what is the diagnosis or differential diagnosis?
Stroke.
Sorry?
Stroke.
Okay, so this could be a stroke. Now, can anyone tell me what are the signs, symptoms of stroke in this patient?
Blurred speech.
Blurring of speech.
Wonderful. So we go one by one. This is elderly people, more commonly seen in elderly. Anyway, unable to speak. So number one, speech problem. Okay, that could be all of the sudden, right? Unable to speak, right? Second,
Right hand agitation.
unable to make some word, appropriate word. Second, right?
Yes.
So this could be the stroke, right? Can anyone know the fast full form of be fast? Be fast in stroke.
Facial dropping. Facial dropping.
I want to
Uh,
know all
F,
six things for be fast.
B for balance.
B for
sir, we do
balance,
only know the fast.
E for eye changes, vision problem or something like that.
eye problem, you can say.
problem you can say.
F for
Facial drooping or
Facial.
facial distortion.
facial drooping, facial
Facial shape.
asymmetry, right?
Yes.
A for
Arm
Arm
weakness.
A for arm
arm,
power.
arm weakness,
weakness.
power, arm weight, blah blah. S for
Speech
speech.
Slurred
As per
speech.
speech.
Speech. So difficulty in speech, slurred speech, unable to organize, make words, blah blah. So everything related with difficult speech. And T for time.
Timer.
T for time of onset.
Is that clear? Yes or no? So you must remember
Yes.
the be fast. So any patients to your emergency comes tomorrow morning or any time, you must see the be fast. If you have be fast things, means he is a means he has a stroke. So this is a be fast. B for balance. So change in the balance is also a signs of this, right? Most of the people knows fast, but this is now be fast, right? So balance changes is
Yes.
is because brain is not getting the blood supply, so balance is gone. Posterior cerebral artery, cerebellum is not supplied well because of thrombosis. Balance, is that clear? Yes or no? Something
Yes.
wrong in the internal carotid artery or thrombosis, which is the branch of retinal artery. Again, temporal arteritis, there is a clot, and one of the branch of temporal artery is a retinal artery. Eye problem. Facial asymmetry, right is normal, left is little down, or there is a paralysis, right? Arm means one eye is okay, but this is unable to raise the hand above the elbow, I mean shoulder. Then there is a difficulty in speech, slurred speech, blah blah blah, lot of things. And time is important, because on the time frame you gonna supposed to treat the patient. So if I can ask you, if the patient of stroke comes to you, right, what is the time frame, how you supposed to do, or what are the criteria to treat the patient of stroke? First, let's go by the time. Let's go by the time. Why T is involved here? Why time is there? Why time is important? Is there
The
any
time
change in the
differentiate
management?
between the Yes,
So
sir, ischemic and the hemorrhagic stroke.
recovery.
Differentiate on it.
Mm.
And the TPA administration.
So let me ask you the specific question. If some patient comes to you immediately, or some patient is sitting in your OPD and develop B fast, you think it is stroke, zero, right? What is the on the suspicious of stroke? What first investigation you will do on suspicious of stroke like this patient only? What is there is no option. What investigation you will do?
That is
CT scan,
fast.
sir.
The criteria.
CT scan.
CT
CT
without
scan.
CT scan.
Plain or
So the B,
contrast?
sir, in the
Plain.
OPD, we should do
Plain.
first the fast
Plain.
evaluation.
Plain.
Plain, wonderful. You don't need contrast to see the hemorrhage. What the
Hemorrhage.
most biggest thing is, you need to just exclude the hemorrhages or not, because stroke, all right? First of all, we need to know the stroke. So how the flow comes when patient comes to you, they have 100% any of the B fast. Is that clear? After B fast, you suspected, you need to do the CT scan. CT scan,
Yes,
plain
sir.
brain. Why you need to do? Because you need to differentiate whether it is hemorrhagic or it is ischemic. 80
Yes,
90% are
yes.
ischemic, 10 20% are hemorrhagic, right?
Hemorrhage.
Right, why you need to know? Because treatment is absolutely 360-degree change. So this, you cannot avoid this. Without this, you cannot treat any patient. Without CT scan, no stroke patient can be treated. So now you get to know, okay, there is no hemorrhage, it is ischemic stroke. Now the time frame will come in the picture. See the flow, right? See the flow, learn the things, right? You don't need to mug up. At 0 hours, at 1 hour, at 2 hour, at 3 hour, at 4 hours, at 5 hours, and at 6 hours, is there any change in the management? If the patient developed stroke at 12 o'clock, means 0, he comes at 1 o'clock, he comes at 2 p.m., he comes at 6 p.m. Is there any treatment change in the ischemic stroke which is confirmed by the CT scan plain, right? And patient has a neurological symptom, patient has a B fast, you need a CT scan plain, it's showing the 80%, I mean 80% cases are ischemic, and you confirm it is a ischemic stroke. You rule out the contraindication of thrombolytic, and now you want to give the thrombolytic. So what is the treatment change if it is present immediately within 1 hour and he comes after 6 hours?
Thrombolytic therapy.
So the first 4 hours we can give the patient the TPA.
TPA.
After that is
Okay,
TPA.
so
after
can anyone
4.5
tell
hours
me
is quantitative.
thrombolytic therapy can be given just little specific up to 3 hours or 3 to
Yeah,
4.5
90.
hours? 1 minute, 1 minute.
So
Up to 4.5
3 to
hours
4 hours. 3
or
to 4.5
4.5
hours is
hours?
the answer.
4, 5, okay, 3.
Up
3
3
to
to
hours.
3
4.5
hours.
hours.
And 3 to 6 is extended window.
Maximum 4.5.
If you have 3 options of thrombolytic, which is the best option? Up to
Up to
3
3
hours,
3.4.
hours.
3
3
to
3
to
to
4.5.
4.5
4.5.
best, or more than 4.5 is the best to
3 to
give
4.
thrombolytic?
3 hour.
Up to 3 hours.
Up to 3 is the best answer,
3
let me
to
tell you.
4.5.
Because
Otherwise, it is
faster,
an extended window.
faster you give, better the result, right? It will open up the arteries, whatever the anterior, middle, posterior, cerebral, wherever the block and clot is, right? So high, if you can give it at 1 hour, no need to wait for 2 hours. If you can give it within 2 hours, no need to wait for 3 hours. Earlier the better. So among this, up to 3 hours, absolutely there is no controversial by my knowledge in the guideline. Up to 3 hours golden hours you can give ischemic stroke TPA. Is that clear? Yes or no? By my knowledge,
Yes, sir.
again, few guidelines says up to 4.5 hours is like fine, okay, no problem. Risk benefit, you have to see the risk benefit ratio, right? After 4.5 hours, it's bit doubtful, or you probably not get that advantage of giving TPA, right, in ischemic stroke. Is that clear? Yes or no?
Yes, sir.
Right, so we need to review once again the literature, but I think this is like so far what we practice in our things, and that is what it's written in the book as well. Time frame thrombolytics. So after 6 hours you just give the aspirin, that's it, you don't give this, you cannot offer anything else, right? Because giving the thrombolytic, because whatever the damage neurons, this is done, it's done forever, that's
That
it.
have to already establish.
Yeah, that is all established, so there is no logic
No
giving them,
benefit.
no benefit or no logic giving it, right? When poisoning patient comes to you after 12 hours, no need to do the gastric lavage. In 12
No.
hours, everything is gone in the circulation. So what you
Yeah.
do by doing the or washing the stomach, you understand? So it's within 2 hours, it's important. Same things logics apply here. So this is what the answer is. So most accurate test is CT scan, right? I already mentioned you everything in detail. So I just go through it.
If some stroke is excluded, then we go to for angiography. Contrast enhances
Yes, that's
CT.
correct. Yes, that's correct. So first we do the CT scan for your knowledge. If CT is
Yes.
inconclusive, say for example CT is inconclusive, equivocal, then you do the MRI because MRI is more sensitive and specific for the brain and to also have the exclusion of the hemorrhage. Because in stroke patient, your major concern is to give the treatment as soon as possible. And before giving antithrombolytic, you need to rule out the hemorrhage. That's it. So
Yeah.
this CT scan is available frequently. So easy, available, affordable. That's it. So MRI is not that frequently available in major centers, in many centers, sorry, right? Except the quaternary and tertiary, they may have MRI. Otherwise, CT scan available everywhere. So you don't need to be a very hero to do a MR or MR angiogram or digital subtraction angiography, blah blah. Don't require. Just do the plain CTs. Exclude hemorrhage is there or not. If no hemorrhage, start TPA. That's it. If they fits into the time frame. Is that clear? Yes or no?
Yes, sir.
Excellent, wonderful. Let's go little pediatric and little switch your gear from neuro and onco to now little pedia. 2 years old boy is brought for the evaluation after having diminished appetite for past 12 hours. His mother reports that he was in his usual state of the health until earlier in the day when he had a bout of emesis. Since then, he has had 4 additional episodes of emesis, will not tolerate any solid food and has only taken sips of liquids. Only physical examination on physical examination, he is afebrile, oxygen saturation is 99, while breathing ambient air. His lung fields are clear on auscultation. He has no erythema in the oral cavity or oropharynx and no tenderness in the neck. His abdomen is soft. 2 views chest X-ray is obtained, which is there on the right upper corner of your the slide. So you can see the X-ray. Which of the following is next best step or appropriate most step in the management of this patient? Use of catheterics to induce vomiting, CT scan of neck and chest with contrast, rigid bronchoscopy with foreign body removal, esophagoscopy with foreign body removal, trial of oral feed to follow the foreign body to pass to the stomach. Right? So don't yet be in a hurry. Never ever miss my trial. If you remember this, you have a lot of advantage. So you need to first make a diagnosis. Without that, you cannot jump on the management. If you make a diagnosis of this patient, what's wrong with this patient, your job is easy. Yes, Safa, any Dr. Safa Aisha, any comment?
Sir, it looks more like a foreign body.
Foreign body in where? Esophagus, stomach,
Esophagus.
trachea, larynx,
Esophagus.
bronchus, trachea.
Not in trachea.
Esophagus.
The respiration seems to be clear. Even the lung fields are clear on auscultation. So it's more of esophagus.
Okay, so more of esophagus. So what you do for this foreign body in esophagus?
Endoscopy.
Excellent. So it's a simple esophagoscopy with the foreign body removal. That is the answer. That's it. So you can see the foreign body clear cut in upper part of the esophagus stuck, and because of that he has a vomiting. Respiratory is not compromised, so absolutely it is not in the respiratory system. So no need to worry. Right. So answer here is the D, though it is a little easier question, but that's fine. So here I'm not going much in detail. The patient has a button battery lodged in the esophagus as indicated in the radiograph. Recognize the shape of the battery compared to the other foreign body is critical because it affects the management. On the anterior-posterior radiograph view, the button battery will appear circular, rim and halo effect near the lateral edge. Right, no need to go much in detail of radiology, but this is so what you do when the battery ingested is identified. Esophagoscopy with removal should ideally be completed within 2 hours of the ingestion time to reduce the morbidity and mortality. Longer the battery remains in the esophagus, greater the degree of mucosal breakdown is there. Unrecognized battery ingestion lead to large proportion of leads to large perforation of the esophagus and can even result in a tracheal perforation. So eventually, so sooner the better, you need to remove this. Is that clear to you? So this is what classical, you can see this battery. It's a radio opaque. One of the easy questions, but little tricky to understand. Patient with iron deficiency anemia is being started on the treatment with oral ferrous sulfate. Which amongst the following is earliest indicator of response to oral iron? So somebody has iron deficiency anemia. You started on oral iron. Now you want to know the response and you want to know which would be the first one which will increase, or by knowing which, you know that this is the earliest indicator of response, that whatever the oral iron you give for iron deficiency is going to work on this patient. So what's that parameter? Increased hemoglobin, right, is the earliest indicator of response to oral iron. Reticulocytosis is the earliest indicator of iron. Normalization of serum ferritin is the earliest indication of iron, oral iron response to the therapy. And increased MCV, that is mean corpuscular volume of RBC. How are you gonna supposed to know? Iron deficiency is global. Yes, Dr. Mahim,
MCV.
any comment?
Reticulocyte.
Okay.
Increase MCV.
Okay. So how MC, what when the how you supposed to, what is MCV, I mean, or how when
Mean
suppose,
corpuscle value.
wonderful. So say for example, patient has
It's
a
TV.
patient has a hemoglobin 7 and iron deficiency anemia. Example. Now you started the oral iron you started. So when hemoglobin increase, when MCV increase, when reticulocyte count is increase, when ferritin will increase, when bone marrow erythroid hyperplasia will increase. Now tell me. If you want to tell me in the day, you can tell me in the day, sir. Okay, 10 days, 15 days, 1 month, blah, blah, blah. More specific questions for better understanding. And this is all for better understanding. Now open for all. Anybody can answer now. Yes, Lalit, any comment? You had given the answer a hemoglobin. That is not the answer, but I want to hear your logic. Hemoglobin is not the answer. Yes, anyone? Though it's look easy, but it is everyday's job, na? Iron deficiency, you see more than leukemias in your OPD, in my OPD as well. I'm though doing
Yes, sir, it is a
exclusively.
common.
Very common, very common. The most common scenario. You started a oral to many patients every day, but we don't know what is the best indicator to know the iron response. What you had given, how we supposed to monitor
To be
fast?
honest, we never thought of this.
Reticulocyte increase
Okay,
3 to 7 days.
okay, fair enough. Let's see. Yes, Dr. Garavi, Jelve Garavi, your comment. When hemoglobin, when MCV, when retic, when ferritin supposed to increase. Anyone wants to make a comment on this? For all these things. Now you can give me the later on answer. This slide will self-explanatory. So I don't need to give you answer. You can understand, you all are brilliant in the batch. So whenever you give the oral iron to any anemia patient, so you have anemia means low HB patient. Iron deficiency anemia means ferritin is low. That is the hallmark of iron deficiency, low ferritin, low iron and high TIBC. This is classical of iron deficiency anemia, right? You have hypochromic microcytic in peripheral smear. You have low MCV. You may have low MCH, right? This is classical for iron deficiency anemia, right? So once you had iron deficiency or you started the oral iron to the patient, this is what exactly time after iron administration, it is in hours. So let's go one by one. Response, what response, right? So today is the 13th of date. You started patient 13th of July. You started one patient on oral iron within 24 hours, means by tomorrow, 14th of July, what happens to his body? replacement of the intracellular ion enzymes, subjective improvement, the most important subjective improvement, decrease irritability and increase appetite. So within 24 hours, symptomatic improvement will be there. In short, symptomatic, which is not in the option. So this is not the answer, but symptoms will improve first, irrespective of whatever happens to hemoglobin, blah, 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 blah. Right? What happens in next 24 hours? Right? So 36 to 48 hours means I can say beyond 1 day to up to 2 days. Very fast. What happens? Initial bone marrow response. So first response you see in the bone marrow, though we are not doing bone marrow on second or third day after starting the oral, but for your knowledge, what happens in the body? Symptomatic improvement because of iron uptake is now in the cell and RBC. After that, initial bone marrow response, erythroid hypoplasia. What bone marrow? Erythroid hypoplasia. Erythroid means RBC, hypoplasia means increased formation. So now the RBC formation gonna increase, right, for this patient, right? So that is most thing, but we are not doing bone marrow, right? Then third thing, what happens 2 days to 3 days? Reticulocytosis, 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 and that start at the 2A and it will remain elevated for 7 days. What happens after 3-4 days up to 30 days? Increase in the hemoglobin, that the time is 4 to 30 days. Dr. Pradeep, 4 to 30 days, and 1 month to 3 months, replenish the store. Replenish the store means ferritin level will increase. Is that clear to you, everyone? Yes or no?
Yes, sir. Absolutely clear.
Yeah.
So now onwards, when you give the oral iron to your patient, first ask the symptomatic improvement in the next visit. Anyway, he will not going to come on the next day, but definitely patient, the first is symptomatic improvement. You will not going to do, or I'm strongly not recommending anyone to do the bone marrow on the third or fourth day. Absolutely. I muted all because background noise. So the next is the reticulocyte count. So if you want to do the earliest marker, what happens, right? There is erythroid hyperplasia, which eventually do the reticulocytosis and which eventually make the red blood cell, which eventually increases the hemoglobin. And after normalization of hemoglobin, you give 2 to 3 months of oral iron, which will increases the store. I have excellent PowerPoint presentation and approach to anemia. Let me know. I will forward it to the group so you can go through that 30-40 slide. Excellent prepared on just anemia, only anemia, right? All anemia covered. So that is very important. So now what do you think if I go back to the scenario or questions? Is there any change in your answer, or would you like to change your answer, whatever you had given? A patient with iron deficiency anemia, right, started on the ferrous sulfate or oral iron you started, which amongst the following is the earliest indicator of a response of oral treatment? Hemoglobin may take up to 30 days. Reticulocyte 2 to 7 days. Normalization of ferritin means 3 to 6 months. And MCV will take definitely a long time because you are changing in the shape. This is the mean corpuscular volume. So this is normal, right? So this is volume. So volume may take changes, right? Probably weeks. So if you have hemoglobin of 7 and MCV of 60, right? And reticulocyte count of 1% at the time of presentation, what happens after 1 week? Hemoglobin will remain 7, MC will remain 60, retic from 0.51% to become now 3 or 4%. Means earlier indicator. After 4 weeks, if you give the oral iron to the patient, this hemoglobin, right? This hemoglobin will become 7 to 8 or 9, 1 to 2 gram with oral, right? 1 to 2 gram per month, they increase. Then MCV is little increase, and this is normal now. This is normal. And after 3 months, this will increase, this will increase. So it will not increase immediately. The most earliest indicator is the retic count, and even faster than retic count is erythroid hyperplasia in bone marrow, which we are not recommending invasive procedure. but for your knowledge, I'm telling you. Is that clear to everyone? Yes or no?
Sir, may I ask one question? Good morning,
Excellent.
sir. Good
Very good
afternoon,
morning.
sir.
Yes, please. Ask the
Sir,
question.
last time I gave the exam of OMSB and I found one question I still remember. Sir, they asked for me what is the best first single choice for iron deficiency anemia.
Very true.
What we have to give the patient oral ferrous sulfate, iron IV, and have a different 5 to 6 options, and none of the above. These are choices. So, sir, what should we go for? This is oral ferrous sulfate is a correct answer, or we have to use
No,
another choice?
let me tell you, every see, there is a no one answer for all. Anemia, I'll give you quick one example. If patient is young, orally they can tolerate, right? Oral iron is the
Okay.
number one choice, right? If patient is not
Yes, sir.
tolerating, side effect, compliance is poor, then you give the IV iron. Sometimes in emergency, say for example, 9 months of amenorrhea, patient is going to deliver in 1 week and hemoglobin is 7 gram, 8 gram. Oral will not work, na? Oral will take 1 month or at least 3 4 weeks to increase. In that case, it is emergency. So you give either IV iron or blood transfusion. So there is no one answer. But if I can give you the stepwise approach, then oral would be the first choice for all patients. So those who are tolerating well and mild to moderate anemia. Severe anemia oral is not. Patient with road traffic accident, hemoglobin is 4 gram. You can't start oral iron. You give blood transfusion. Is that clear? So every
Yes,
anemia depends on the context of the question. You need to little adjust the answer, right?
yes, sir.
If
Thank
young
you very
female,
much.
yeah, so if young female of 25 years iron deficiency, multiple pregnancy, heavy menses comes to me, I'll give oral iron. Absolutely, she is fine, young, no comorbidity, no cardiorespiratory thing, absolutely fine, no emergency increasing, right? But the same lady comes in the emergency with postpartum hemorrhage with 4 gram, I can't give oral, I have to give the blood transfusion. Is that clear to you?
Yes,
Yes or no? So
yes, sir.
you
Thank
need to,
you very much, sir.
no problem. So you need to see the context of the questions, how and what they exactly ask, right? So there is no one shoe fits everyone like that only. So you need to see the thing. So scenario is very important, and that is why always I'm stressing on the scenario. You need to read the scenario quite well. You can't jump to the scenario very blah 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 fast, right? So this is
Excellent.
what the, sorry,
Thank you very much.
you got the
Sir,
answer or
excellent.
not?
Thank you very much.
Do you have any question?
No, sir. Thank you very much. Wonderful explanation.
Wonderful. Thank you very much. Let's check one more questions with then we have probably yes 34-year-old multigravida presents for prenatal care in the second trimester. She reports the history of substance abuse but state that she has been clean for last 6 months. With her second pregnancy, she experienced a preterm delivery at 24 weeks of gestation of male neonate who died within the first day of life. At that delivery, the baby was swollen with the pink lesion, with the skin lesions, and the placenta was very large. She was treated with antibiotic, but she cannot remember what they were. I mean, she didn't know what the antibiotic was. On the routine prenatal panel with this current pregnancy, she is found to have a positive VDRL test. Which of the following next step in the management of this patient? Are you going to do the FTA ABS? Are you going to start intramuscular penicillin for this patient? Are you going to do the lupus anticoagulant for this patient? And are you going to start the oral penicillin for this patient, or are you going to go for RTR? That is the name of the test. So we'll dissect little questions so you get better clarity. So you think over it again. I don't want you to miss my triad. So again, ask yourself 3 questions. What is the diagnosis of this patient? How you gonna investigate this patient? What is the treatment of this patient? So there is one question, but there is a 3 questions. Yes. So what's the diagnosis? You look into it. This is probably the last questions for discussion today. So you take your 10 15 seconds more and try to give me, sir, this is the possible or likely differential diagnosis of this patient.
Syphilis, sir.
Sorry.
Syphilis.
Okay, so let's
Syphilis.
put the syphilis here. Syphilis. Okay, fair enough. Anybody wants to have any comment? I would be glad and happy to have it. Yes. Any other comment? What could be the answer? You read the scenario, no? Everything is there in the scenario. If you develop the art of reading this, honestly speaking, believe me, you don't need to see this. You will click the answer in your mind, and that would be in the options, believe me. But you need to prepare yourself. You need to do practice again and again, again and again. More the MCQ you practice, more the excellence you develop. Nothing comes, nothing magic. I am not super duper or extraordinary. I solve more MCQ than you. That's it. Simple. If you do more excellent, you are welcome to present the lecture on behalf of me. Welcome.
FTA ABS. Next step in
Sorry?
management.
Sorry?
FTA ABS. Next step in management.
So your answer is, sir, FBA, FTA ABS. That is your answer, right? Can you
Yeah.
tell me what is FTA ABS full form?
Fluorescent terpenomal antibody absorption test.
Okay. And what is VDRL test full form?
Venereal disease reference laboratory.
Sorry, venereal disease?
Reference laboratory.
Okay, fair enough. So what advantage you will get by this FTABS? Do you get any advantage of by doing the FTABS? You are suspecting this lady, she has a positive VDRL. You can't directly jump on the treatment. She has VDRL positive. So why you don't want to switch to the treatment? Why you want to do more further testing for this?
False positives are high in VDRL, sir.
Sorry?
False positives are high. There are other conditions also in which she can be VDRL positive.
Okay, so VDRL positive. Anyone can help me to prepare a list. What are the conditions where the VDRL is positive? One is
But
syphilis.
that will be in initial stages of pregnancy, the VDRL positivity, false
Okay.
positivity.
So
Not in
initial
the
stage
late
of
stage, like
initial phase of pregnancy, syphilis. These are the two.
Yeah.
Any third one? Anybody wants to comment? Third one? Or these are the only two conditions globally where VDRL is positive? Sorry?
Any immunosuppressive disease.
Leprosy.
Okay, one is leprosy. Fine. What else?
Autoimmune disease.
Drug induced.
Right. So yeah, you are right. So let me give you the short form of VDRL as well. Everything I want to make it simplified for you every time. So V, viral infection, especially infectious mononucleosis and hepatitis. D means drug. There are many drugs. Common is procainamide and chlorpromazine. D, R, rheumatic fever. L, lupus and leprosy. Is that clear? Yes or no?
Yes, sir.
Yes or no?
Yes, sir.
Wonderful. So this VDRL positive does not mean it is syphilis, right? It could be any of this, right? Because VDRL is positive in VDRL. This is how I remember acronym like acid, right? So you need to first confirm, right? And how you gonna do it? Right? Then A is the answer here because you need to confirm. It could be false positive. Before jumping onto the treatment and patient is pregnant, you don't want to do any mess up with this. So next step after any positive screening test is confirmatory test. Say for example, preoperatively HIV rapid is positive. So you can't start directly antiretroviral. You're gonna do right the first ELISA and eventually you may probably do the Western blot. Am I right? Yes or no?
Yes, sir. Absolutely correct.
Right. So whenever you have a screening test positive, you need to confirm that test because there are lots of false positive things are there. ANA positive does not mean you start the treatment. ANA positive in 100 of condition, right? After that, you have to confirm with the ANA profile. You need to find the specific antibody and then you can name the thing. Okay, this is Sjogren syndrome. This is systemic lupus erythematosus. This is mixed connective tissue disorder. This is a giant cell arthritis. This is this. You understand? So depends on the specific thing. So here you have a VDRL, which is a screening test, which is positive. So now you want to do a confirmatory test, and that is FTA-ABS. What do you mean by FTA-ABS? As you rightly mentioned, fluorescent treponemal antibody absorption test. We need to know the full form as well, being a doctor. Or this is the another name, which is more complicated, but FTABS, confirmatory test. FTABS is a confirmatory test for syphilis. Once the syphilis is confirmed, means what? FTABS is positive, then you can give the intramuscular injection. That is the next best option. So if somebody says VDRL positive, what's next best? FTABS. In your exam, ask, you have patient which is FTABS positive, what's the next step? Then intramuscular penicillin. Is that clear to you? Yes or no? At least tell me yes or no.
Yes, sir.
Yes.
Right? Sensitivity of diagnostic test by stage. So there are primary syphilis, secondary syphilis, tertiary syphilis. You go and read it, right? So in primary syphilis, VDRL and RPR is the test, right? Primary syphilis, and this is more sensitive and specific. See, these are the 75% is 95. And here you can see secondary and tertiary 100. So highest sensitivity and specificity is FTA-ABS, irrespective of the stage, whether primary stage, secondary stage, or tertiary stage. FTA-ABS has highest sensitivity and specificity. Can you see by the numbers? Yes or no? Are you getting me? Yes or no? Right? So this is the best test to go ahead. And once this test is confirmed, you're gonna go for the treatment of these patients. So thank you very much all for, yes, please.
So the VDRL and RPR has the same sensitivity, so we don't need to do RPR after if the VDRL positive.
Yes, that's correct. That's correct.
So what should be the first line of investigation? VDRL or RPR?
You can do VDRL or RPR because you can see the whatever the available, because both have the sensitivity and specificity. They have mentioned in the percentage stage wise, primary, secondary, and tertiary, right? So if you have
So we have
VDRL,
seen the practice that
VDRL is widely available by my knowledge,
Sir,
right?
RPR
Yes,
will
sir.
give us titer.
Yeah, that is more
RPR, sorry,
important.
what?
RPR will give us titer. Like what is the titer? It is 1:4, 1:8.
Like
16.
what we see in the this salmonella typhi, right? When we, typhoid, when we
Titer.
give 40, 80, 60, 163, 20, blah, blah, they are giving, right? So that probably higher number means more level of bacteremia or viremia in the blood or so, blah, blah.
Bacteremia.
Yeah.
And so then we need to give 3 injections if RPR is positive at the interval of week. 1.2 benzathine penicillin, 1.2
Great.
international.
Great. So
3 injections
great.
are required.
So that's all. Thank you very much for from my side. I would be glad and happy to have little quick feedback for someone who learned something new today. I mean, obviously, everybody has a different mindset, but I would like to have little quick feedback, 5 minutes, especially how you enjoyed the class, because I enjoy every time. I want to know
Very
you.
wonderful, very
Yes.
very easy way to understand and logically.
More than
Excellent.
that, sir, it is very stimulative. Still, we
Wonderful.
want to learn at this stage. Also, we want to learn, and we are learning from you. It's a really good, sir.
I am
I
also
remember
learning.
my OP Kapoor, sir. I remember
Sunday
my OP Kapoor.
brainstorming.
Yeah, I'm also learning, madam.
No, sir. We are learning from you, and it is really like very, very stimulative. And our
Wonderful.
brain gets more activated, the cells are more
No,
activated, the release
no.
hormone.
Thank you very much. I
It's
want
the
you to,
dopamine also.
I
Dopamine
want,
also. Dopamine
great.
is more in our brain.
I want you to motivate, and
Happy
I want
journey.
you to learn, and I want to share my expertise and experience of last 20 years of extensive clinical practice. And that is why I'm unbeatenly, untiredly, I'm doing mock test on every Sunday. You must be seeing it, right? So I'm not skipping as far as possible. So, I mean, anyway, I'm happy to guide you all guys. So that would be probably helpful to you, all these things. And I get a lot of feedback from the past student. I think somebody who cracked the exam recently. I think that lady probably joined. I don't know whether she is there in or not. So they give us the feedback, sir. Whatever we learned in the lecture, I mean, line to line, and they are remembering me in the class, in the exam hall. You understand? Because word to word is coming and the same MCQ is coming, copy paste is coming. So obviously, I mean, they will be happy, no?
Your teaching is not only for the PROMETRIC purpose, it is to day-to-day clinical practice also, sir.
Yeah, thank you very much, sir. Thank you very much. Thank you very much. Anyone else, last but not the least, any comment?
Sir, do we
Your
need
way of teaching
to,
helps us to
sir,
do more
sir,
MCQs, sir. Practice
Yes,
more.
yeah. No, I will try to take more lectures, but because of time strain, doctor, honestly speaking, I'm stretching myself to, and I don't want to lose this opportunity to be with you. Otherwise, it's, it's very, very time is a major constraint. Except Sunday, it's very hectic for me in the hospital. But anyway, I'll try my level best to catch up with the more things and more lectures. Probably we'll start with twice a week instead of every Sunday, probably Saturday, Sunday. So let me stretch it a bit more.
Sir, try
sure.
Yes,
try
sir.
best.
Thank you very
Sir,
much.
what would you
Whatever you
suggest
are,
to do the MCQ? Sir, I have a question.
sir, whatever you are
If you allow.
doing, that is for your nation. This is for nation. Of
Dubai
course,
nation.
this is for nation. Your
Thank you.
contribution.
Worldwide,
Dubai nation.
worldwide it is, not only in India,
Thank you
worldwide.
very much. Thank you very much. Thank you very much. Okay,
Thank you,
sir. So
sir.
enjoy your Sunday and keep in touch with
Thank
me.
you. Thanks a
Right.
lot,
You
sir.
Thank you,
can,
sir.
those who missed, I mean, we'll send you the recording as well. Thank you very much.
Thank you very
Thank you,
much.
sir.
Take
Sir,
care.
I have a question, sir.
Thank you very much.
Motivated us.
you.
Thank you very much.
Thank you very
Thank you,
much.
sir. Thank you so much, sir.
Take care. Take
Thank you,
care.
sir.
Take care. Take care. Bye bye.